Greetings and welcome. Thank you for joining us today for our fourth week of this year's HIV Prevention and Education Virtual Summit. My name is Kyle Shavasta, and I am the Public Programs Manager here at the Community Health Training Alliance and Education and Training Program of Philadelphia Fight Community Health Centers. We've been learning so much together this month about the issues that impact the lives of people living with HIV and how we can better provide care and service delivery. And today we have another pertinent topic in store for you today. But before I introduce today's topic and speakers, I just want to go over a few brief house rules. The chat is disabled. However, you can ask any questions you have in the Q&A box below. We'll facilitate all questions at the end of today's presentation. Today's presentation is being recorded, and you can view this and all other webinars on our YouTube channel. Once the webinar is completed, please just hang tight and let the screen pop up, because once this webinar concludes, you'll be able to take a survey and let us know how we're doing. So with that said, I am pleased to introduce today's topic and speakers. With us today, we have Michaela Jackson and Andrew. Michaela Jackson has worked to educate and raise awareness on various public health issues at both a local and national level. Her work at the Hepatitis B Foundation currently focuses on implementing public policy initiatives to address hepatitis B and liver cancer prevention. Andrew is the spouse of a hepatitis B patient who has been negatively impacted by discriminatory drug tiering. He is a patient advocate who wishes to raise awareness around the high cost of hepatitis B treatments. Today, they will be presenting the true cost of discriminatory hepatitis B drug tiering. Thank you both for being with us today. And with that, the floor is yours.
Hi, everyone. Thank you so much, Kyle, for turning that over to me in the wonderful introduction. My name is Michaela Jackson, and I am the Prevention Policy Manager for the Hepatitis B Foundation. And so today we're going to be talking a little bit about an issue that affects both hepatitis B and the HIV world. And then I will be turning it over to Andrew to talk about his lived experience with this issue and why it's so important that we really pay attention to it. So to begin, we're going to talk a little bit about what hepatitis B is, because it can be a little bit of a complicated topic. And we're going to talk about the state of hepatitis B in the United States before we delve right into the issue, and then I turn it over to Andrew. So hepatitis B is a viral infection of the liver. We do say it is a silent infection because it has rarely any symptoms until it progresses to a later stage. And that later stage will either be significant liver damage or liver cancer. About 1 in 4 individuals who are left untreated for hepatitis B will develop significant liver damage or liver cancer. It can be acute or chronic, so short-term or long-term. And hepatitis B has no cure. So really, we only rely on management and guidance from providers to help pave the way for people living with hepatitis B. And it is preventable. There are several highly effective vaccines that are existing out there. Unfortunately, in the United States, that adult vaccination rate is extraordinarily low for many reasons. So hepatitis B is still a prevalent issue in the US today. So what is the connection between hepatitis B and HIV? It's a dangerous co-infection, one that can actually lead to the faster progression of liver disease. About 5 to 14% of HIV-infected individuals in the US are living with hepatitis B as well. That number's an estimate because we don't really have a great surveillance system in the United States. So we have to rely on outdated numbers and estimates to really get the data that we're looking for. Hepatitis B is also transmitted similarly to HIV, which is why we often see it in the same populations. It can be transmitted sexually, mother to child. It can be transmitted through injection drug use as well. And these co-infections are really complicated. Not only is it faster progression of liver disease, but it's a higher risk of hepatotoxicity after beginning HIV treatment as well. So when you look to the right or the left of your screen, we can see Jason's story, who is an individual who is actually living with HIV and hepatitis B co-infection. And he's one of our Just B storytellers, so a person who is living with hepatitis B and has experience and wants to really raise awareness about his experience to help educate a broader population. And so you can see, if you read that little excerpt from his story, he talks about how doctors sometimes have little experience treating hepatitis B and HIV co-infection, and actually his particular doctor that he was first working with put him on a higher dose of medication than might have actually been needed, which caused him to develop kidney disease on top of living with HIV and on top of living with hepatitis B. He actually fell into depression, but fortunately he had his family there to support him, and now he really dedicates his time to raising awareness of why people need to be tested for HIV, why people need to be tested for hepatitis B, and why treatment is necessary in some cases. So in the United States, about 2.4 million Americans are actually living with chronic hepatitis B. Hepatitis B, unfortunately, is not something that's discussed a lot, but you can see it is a pretty high number, and we're actually seeing rises in certain states, and I can discuss that on the next slide. So hepatitis B in the United States. Unfortunately, this disease primarily disproportionately impacts minority communities in the US. Of note are Asian Americans, Pacific Islanders, and African immigrant communities. Asian Americans actually only make up about 6% of the entire US population, but they also account for 60% of all chronic infections in the United States regarding hepatitis B. So you can see that's a really clear health disparity right there, and one that certainly needs to be addressed if this nation is going to work towards health equity. African immigrant communities in the United States have up to 15% hepatitis B infection rates. 15% might not seem like a lot, but for a vaccine preventable disease and a disease that can certainly be eliminated, it definitely is a very high number. I mentioned that we've actually been seeing rises in acute hepatitis B cases, and that's largely due to the opioid epidemic. This is really significant because there's no universal testing guidelines for hepatitis B, and yet people can be walking around with acute hepatitis B or chronic hepatitis B for many years without having any symptoms. They don't know they have it, but they can still pass it on to other individuals. So unfortunately, that is something that we are seeing with the opioid epidemic and injection drug use increases, and something that we're very, very worried about after the COVID-19, and we're starting to see data come in that's in these populations and seeing hepatitis B in groups that we might not have seen it previously, simply because we've had to see a lot of restrictions and our hepatitis services put on hold due to COVID-19. Important restrictions, but nonetheless, there are restrictions, and we couldn't do the normal viral hepatitis outreach and education and work that was needed for almost an entire year. So that data will be very significant moving forward. And as I mentioned, hepatitis B has no cure. So unfortunately, once you begin treatment, you're often on it for the rest of your life. So if you begin treatment at 30, 40, you're on that for a very, very long time. These medications need to be taken daily. Stopping suddenly is really bad, or taking it only sporadically, because it can actually lead to the virus flaring up in your system, and it can increase your risk of liver disease or liver cancer, which is already negative when you're already at an increased risk for liver disease or liver cancer. So today we're going to be talking about adverse drug tearing. And the reason that the Hepatitis B Foundation really came upon this issue is because we're hearing from individuals. We have a patient consult line where we hear from people all around the world who call in and tell us their issues, or might write us and tell us why they're struggling with hepatitis B, or simply have a question about it. And one thing that we've noticed in the past few years is that we've seen a really significant increase in cases and people who have been calling us, specifically in the United States, for treatment access issues, saying, I'm really struggling to afford my hepatitis B medication. I'm cutting my hepatitis B medication in half. I'm skipping days. I'm going months without it because I simply can't afford it. Can you help me? And that's a really, really pressing issue, again, as people need to take this daily and as prescribed, or else they're running the risk of significant liver disease and liver cancer. So we're hearing from nurses of individuals who just got diagnosed and need treatment immediately, but it's too expensive for them. We're hearing from family members, patients, parents of children, and retirees. And all of these people have different income levels, which can make affording medication quite difficult. And so what are they saying to us? We've had people tell us that they've had $4,000 deductibles with their health insurance before any cost sharing has been applied. They've had $1,200 a month copays. They've had to pay nearly $500 a month for generic medications. In one case, we've had an individual call us and tell us they had to pay $2,400 a month. And for a long time, these people have paid out of pocket, paid these bills until they simply couldn't afford it anymore. And we're here to talk today about why that's an issue, why it might be discriminatory, and why it might be illegal in some cases. So adverse drug tiering, to simplify it as much as possible, the way you can describe it is that it's an unfair way for insurance companies to simply place the burden of the cost of medications onto the consumer. So no longer is that cost coming out of the pocket of the insurance company, it's coming out of your pockets, and they're keeping some of that cost. So they're reaping benefits from that, and they're saving money. At the end of the day, one of the most important things that I want to highlight and really emphasize in this presentation is that it is illegal in certain cases. It is in fact discriminatory against individuals who are living with chronic illnesses, again, because a lot of the time these people are taking medications daily. They're taking it year after year after year for the rest of their lives. In some cases like hepatitis B, this is not a sustainable solution for anybody. And these are typically done through hidden benefit plan designs. So the average American is not necessarily up to date and that familiar with how insurance companies work or how benefit plan designs work. They get a plan, perhaps from their employer or another place. They read it and say, okay, it looks good, but they don't really understand the full details. It's a very complicated process. So no one's expecting you to understand the full details, but unfortunately, that's part of the reason why they get away with these discriminatory plan designs. So a few examples of what we're seeing are co-insurance rates. So co-insurance rates means that instead of paying $5, $10, even $100 a month for 30 pills or 31 pills or whatever, you're actually paying 30, 40, 50% of $900. And $900 is about the average for a generic treatment for hepatitis B. So you can see that's a major cost difference to go from paying even $100 a month to all of a sudden 40% or 50% of 900. We also see generic treatments with high cost shares. Generic treatments are generally supposed to be more affordable for the population, but if it's the same price as brand name, you're not really receiving any benefits as the consumer. Mandatory physician's approval for first line or generic treatments, which should already be more accessible, and placing most or all hepatitis B treatments on a high tier, and we'll see that actually in the upcoming slide. So as I mentioned, this is illegal, but how is it illegal? So under the Americans with Disabilities Act, the ADA, hepatitis B is a protected condition in the federal arena. So right here, we have listed under the Affordable Care Act 3 key violations of the Affordable Care Act that often come into play when we're talking about adverse drug tiering. So one is that discriminatory benefit design. Another one is that when we're talking about these benefit designs, it's not really overt. It doesn't really seem like anything, but the effect of what these benefit designs is doing is to make the average consumer, by placing the hepatitis B drugs on a high tier or any, chronic treatment on a high tier, it's so an individual looks at it and says, oh, that's really expensive. Perhaps I should choose a different plan. So they're actually encouraging people through this design to choose plans that might not be beneficial to them, where they may have to pay more out of pocket and things of that nature. So we're really discouraging the enrollment of individuals in certain plans. And again, that's limiting access to healthcare, and that's not good at all. So what did we do? We actually based our methodology on something that happened in the HIV space. Not a surprise, this is going on with many, many other treatments for various diseases. And one of them in 2014 was HIV. So HIV actually shares similar treatments to hepatitis B, and some of them are the exact same. And so we based our analysis upon a successful policy actions that were conducted by the AIDS Institute and the National Health Law Program, where they looked at several states, and they actually ended up suing in Florida after they brought it to the attention of the insurance commissioner and these companies, and no one did anything. And once they sued and they pursued legal action, they actually got HIV treatments to be placed on a lower tier. This is significant because, as I said, they do share some similar treatments. In some states, but not all, you will actually see the same treatment for HIV and hepatitis B, where if it's marked for HIV, it will be placed on a lower tier with more affordable cost sharing, and hepatitis B might be placed on a higher tier with a higher cost sharing, and it's likely because they took action in the HIV space, but hepatitis B hasn't really brought to anybody's attention. We're still learning a lot about it. So what we have done so far is we conducted an analysis for 2019 and 2020 plans, and we've reported all of our findings in a consumer report that is actually published on our website. Happy to share that with anybody who might be interested. And we looked at the health insurance plans across several states, then looked for trends that actually would increase the cost of hepatitis B treatment. So again, those hidden benefit designs where it looks great, on paper, but then over the year it adds up. And so our analysis, we looked at 284 health insurance plans across 14 states in the US over the course of 2 years, so 2019 and 2020. And now we're going to talk a little bit about what we found and how we really broke it down to get the best analysis possible. So as you can see here, we have an example on the left, or perhaps it's your right side of the screen, of what it looked like in our analysis. And we looked at every single plan, so all 284 plans based upon the federal exchange, because if it's on the federal marketplace, if it's in the federal marketplace on the federal exchange, that means it's subjected to the rulings and guidance of the ACA. So anything that falls on the federal jurisdiction has to follow those non-discriminatory policies underneath the ACA. We looked for the FDA-approved treatments for hepatitis B because those are the ones that you're going to be seeing in an insurance plan if it's FDA-approved. And we looked at silver level plans because those are the most popular for individuals to choose from. So as we look, this is an example of a bad plan, I believe, in the state of PA, and it employs some of those tactics that we talked about earlier. So one, you can see that for tiers 1 and tier 2, low cost and generic brands, we have a copay of $20. That's affordable for most people, but only one hepatitis B drug is placed there. Not everybody is on that drug. Tiers 3, 4, and 5, you can see that they've dispersed hepatitis B treatments throughout those, and there's not much of a difference between what you're paying. You can see that they do not offer several drugs, which also include brand names. Some people can't switch between brand name and generic when it comes to hepatitis B, some for a number of reasons. So the fact that they're excluding a lot of hepatitis B treatments is a problem. The fact that we're seeing 3 generic treatments on the highest tier, and that they're considered specialty treatments, even though that they've been around for a very long time, is in fact a tactic that is often used. And if you look at the deductibles, a person might not be able to tell if they're just glancing at it. Tier 1 has 0. So if they assume they're on entecavir and that it has low cost, they're like, oh, well, this plan might be great for me. When you look a little bit deeper, entecavir is in the last tier, very problematic. Yeah, and for tiers 2 and 3, you can see that it's $6,000 per individual. So again, we're getting up there with deductibles, where these treatments are placed, how many treatments are placed on those high tiers, and then restrictions. Those are all listed, especially if it's not in network, somebody has to pay 30% reimbursement rates for one of their treatments. So when we're looking at hepatitis B treatments, we're looking at these 12 when you add up the generics, FDA-approved treatments. So the 3 with stars on them are the 3 first-line top-tier treatments, and that means that these are the treatments that are most prescribed in the United States by doctors, because 1, they often have less side effects for individuals, and 2, they are often the ones that just work most effectively. So those are the 3 that we're really focused on for this analysis for those reasons. If you take a look, you can see Vemlidy, which is a newer hepatitis B treatment, doesn't even have a generic. So basically you're paying, I believe Vemlidy was a few years ago, around $3,000 to $5,000 was the cost of Vemlidy. So that's a pretty significant cost, especially when it has no generic. We really need to take these things into account when we're talking about access to treatment. Baraclude, entecavir, Invariad, and TDF are all the treatments that we're looking at. And here we're taking a look at the average price of treatments, was updated almost a year ago to this date in July. And you can see that we have listed the average retail price for brand name and generic. When we're looking at generic, you can see that even for the 3 first-line treatments, the lowest generic cost is on average $960 in the United States. Now, again, this does vary across states for a number of reasons and how people are accessing it and a lot of other factors. But on average, this was the cost. It's not cheap at all, even if it's a generic treatment. So what did we find within our analysis? One, we found that deductibles generally had a trend of being required to be met before cost sharing began for higher tiers. Again, those high tiers where we're seeing those hepatitis B treatments being centered around. So if you're requiring $6,000 deductible to be met before they can even get 30% coinsurance, before they can even begin paying $20 a month for their treatment, really problematic because people are having to shell all of that out of pocket. Number two, we have benchmark plans were not met by a majority of the insurance companies. So for a little bit of background, a benchmark plan is a plan that is often given by the state as a model plan, and what an insurance company should be covering for their personal plans and in their benefit designs, what should be covered. So if a benchmark plan, is not really being met, that's not a great thing because that plan is, given and shown as a model for a reason. We've had exactly what we saw with the other slide was that copays are often used for lower tiers, coinsurance for higher tiers. And that's problematic because if we're only having one hepatitis B treatment on a lower tier and most of them on the higher tiers for that cost and coinsurance, a majority of people are going to be paying for that higher tier. And it's important to note that hepatitis B treatments are not all exchangeable. You can't just switch between one and the other for certain reasons. Some are better for people living with kidney problems. Some are better for people with bone density issues. So people are not only living in a bubble with hepatitis B, they have other health issues that take effect and are playing a role in their healthcare. So that all needs to be taken into consideration when we're talking about access to treatment. It's not like, oh, I have hepatitis B, this treatment and this treatment and this treatment, I can choose from either one. It's not how it is. It doesn't matter how the plans work. People need what they need as prescribed by their doctor. Another significant finding was that we found that doses of drugs and the forms of a drug, so for example, powder versus a liquid form of treatments, for the exact same drug varied greatly. So a powder form, which, or pill form, I should say, which is what people mostly take, might have been on a higher tier, but that liquid form would be on a lower tier. That's obviously, not fantastic if no one wants to inject their treatment or if it's not recommended by the doctor. They're actually ending up paying for those differences in forms and doses and drugs. Other common barriers to access that were not as significant, but we still acted as a barrier were prior authorization. So that is requiring your doctor to go ahead and authorize that this treatment is even right for you, even though it's prescribed. It's a whole nother process in order to access your treatment. No mail order options. So this is most significant for people living in rural areas, I might say, or people with mobile disabilities who might not be able to go to pharmacies most often. If there's no mail order option available, they're going to have to go to that pharmacy physically to pick it up. Or if they did offer mail order options, it was often higher costs for mail orders, which can sometimes be a barrier for people who might have to shell out a large amount of money at one time, as opposed to a little bit over a few months to pay to access their treatment. And so in conclusion, just to summarize a few key things that are really important today, it's that despite the Affordable Care Act, we are seeing adverse drug tiering occurring in multiple states. There is absolutely no federal definition at the moment for a specialty drug. This is decided by states and insurance carriers, which means something that we've seen is that some hepatitis B treatments have been declared specialty drugs, even if it might have been generic or something else, despite the fact that it's should be widely accessible, that they've existed for years. And hepatitis B is not a specialty disease. It's a very common disease, especially among certain populations, as we've seen. So there's no way that it should be declared a specialty drug. These medications need to be taken daily for the person's health. If it's not taken daily, this person is at significant risk for higher liver damage or liver cancer. Liver cancer in the United States actually I think globally, it only has about an 18% survival rate in 5 years. That's not great outcomes at all. We really, really need to prevent liver damage and liver cancer before it even progresses to those types of stages, which is why taking medication as prescribed is so essential. Insurance companies can actually change formularies legally throughout the year. This is not something that was entirely discussed in this practice because it's not really covered under illegal discriminatory actions, but it is a significant problem when an insurance company you choose a plan at the beginning of the year, and then midway through the year, an insurance company says, we actually are not going to cover your treatment. So you're going to be out of network, you're going to be paying out of pocket. We actually saw that a few years ago happen with hepatitis B treatment Vemlidy through CVS Caremark, and we had to take action to fight that and say why this was so problematic for people living in the United States when it comes to treatment access. So that's just another thing to take into consideration when you're choosing plans, and might not be there the whole year. And the last thing that it's just a really key take home is that it's extremely important for hepatitis B medications to be both affordable and accessible. And those go hand in hand. You can't just have a hepatitis B treatment created, put out there for thousands of dollars and say, okay, well, it exists, you'll be fine now. It has to be affordable and accessible for people, for the drug to actually work, because if no one has access to it, the drug's not helping anybody at all. So now I'm actually going to turn it over to Andrew to talk a little bit about his lived experience and how adverse drug sharing has impacted his family when it comes to hepatitis B.
Okay, good morning, or however part of the day it is. Hello, everyone. My name is Andrew. Next slide, please. Oh, I can do that. Okay. So my wife is of Vietnamese descent, and as Michaela mentioned, is very prevalent in the Asian community. And she, was actually born with it. Her siblings, some of them have hepatitis B, and some of them do not. And it's my children were all vaccinated at birth, and so none of them have it. And it's actually a regimen of 3 different shots at different ages. So luckily they have, good treatment, and but my wife, no fault of her own and anything. And her uncle also had hepatitis B, and he actually did not have treatment. Side note, not all of the kids, but 2 or 3 of his kids are actually doctors. And so they did, but that, didn't help him. He actually passed from liver cancer. So it's a very serious disease, and almost all the situations that Michaela mentioned for the different adverse tiering or changes in formulary or, all these difficulties, it's part and parcel what happened to me or my wife. And next slide, we're going to go through the story. So fortunately, we got married in California, and I had a job which had HMO, Kaiser Permanente, and they, just due to the large Asian community, they are very good at it. They recognize, the seriousness of the disease, and also, they have experts there. I think our gastroenterologist was one of the foremost experts of it. He was running trials and knew about the complications with pregnancy, and I'm not totally sure, but I knew my wife had hepatitis, and I had already then vaccine treatment, and health physicals and everything. She knew she had it, but with the birth of our first child, I believe it was mandatory testing just to re-verify when she was pregnant, and then monitoring through the blood test throughout the pregnancy, throughout the pregnancy and even afterwards. And as I mentioned, the immediate vaccination with the first dose when the child was born. And unfortunately, each pregnancy, I have 3 children, the viral loads increased, and the treatments were manageable, but we had children that were pretty close together, and there's certain complications with which treatments can happen during pregnancy and breastfeeding. So it seemed manageable, and the doctor was paying attention with it. And we actually on my last child, my girl, she had then the viral loads increased so much that they actually had treatment during pregnancy. I don't recall which treatment that was, but it was just to reduce it due to the stress of the pregnancy, the increased viral loads, and that increase with every pregnancy. There was something done, and unfortunately during breastfeeding had to stop. So as Michaela mentioned, when you stop treatment, it also then goes back up. The treatments are effective. And another thing that happened, and like I said, I became basically very well educated, almost subject matter expert about the disease and treatment. My wife had it, and figuring out how what to do. And he was very, like I said, very good doctor. The HMO was very concerned and understanding, and we weren't special. We were there. So in 2009, after she discontinued breastfeeding, then she began the first line treatment of Baraclude, and it was a very modest copayment at the pharmacy. I believe it may have even been through mail order and a 90-day prescription. Highly effective, monitoring treatment condition and viral loads and blood tests, routine, and even ultrasound of the liver to make sure no cirrhosis or the onset of any kind of liver cancer. And everything was going well. It was manageable. Next slide, please. So so the first child was born in 2005, then 2006 and 2008. Unfortunately, I relocated back to Illinois for family reasons, and there was the time without a job, and so there was big, what are we going to do about insurance? And it's very, very concerning. As Michaela said, it's like, oh my gosh, what are we going to do? And actually, before we learned some stuff, and, we had to do an out of pocket, and no physician, chosen yet. And, just the transition was very, very difficult. But through, Bristol Myers Squibb, which handled the brand name Baraclude, they actually had a program for prescription help. A lot of companies have that for people that are very are required. Otherwise, they couldn't even do it. And like I said, we had started it, and as Michaela mentioned, you really don't want to stop. And one of the main reasons, I'm sure, in terms of like she said about the HIV and AIDS treatments, is the those viruses are nasty. If you reduce or do not have normal or regular treatment and do it all the time, then it actually the viruses can become resistant, and then the treatment itself that was working can no longer work anymore, and then you have to switch treatments, and eventually it may not be effective, and then you run out of treatments. So as she mentioned, we can't wait around for things to work out, and you need to do it every day, and to stick on a regimen that works, and to be monitored, and that. So it was very good. Bristol Myers was able to cover it there while we didn't have health insurance. So that was, it was literally a godsend. That's, it would have been terrible because, with the treatment or the history of the, cancer in the family, and the rate she said 25%. Chronic rates and the viral loads, it was, before treatment, it was, I don't know, they say in the millions, but it went down orders of magnitude. And as she mentioned, it's not a cure. So that as we progressed a little bit later, I found a job, and then health insurance started. It required a couple of months before everything settled out. And but it was already in the Midwest then a tier 4, which was the top tier for their thing, considered a specialty pharmacy, a $200 copay, $2,400 max. And at that time, Baraclude was still a brand name prescription. So instead of a total prescription base, they had actually a copayment sharing or copayment relief or program to help in the high copayments, because that's what the insurance companies did. They had high copayments for the tier 4. So it became manageable again. There's little interruption, and in terms of stress and all the out of pocket, and just how do we deal with making sure that the treatment is there. And next slide, please. So, in 2013, we went there. And then around the time in, the 2015 to 2019, the reason why that is the time that it became trouble is that's when Baraclude became generic. And the, FDA has to certify the generic, and then they have to change, the formularies and stuff like that. And somewhere around 2016, 2017, it takes that long for them to do it. There was, pressures and letters to, we need to switch to generic and this and that. And also back a little bit, jump further back along with the health insurance and changing from the good doctors at the HMO, we had to find an in-network provider here in Illinois, and that was in 2012, 2013. But they had a lot more experience with hepatitis C and other thing. The gastroenterologist really, he admitted, it's like, I really don't see that many patients. Most of them are C, so we're going to continue on with the Baraclude. He really didn't have to change anything, and he'll sign the blood test routinely, and he was able to obviously monitor those and do that. But they just weren't used to it here in the Midwest. And Blue Cross Blue Shield, and it's up to us to pick the doctors, but finding one in network. And during that actually selection of providers, I did, we lived close to the St. Louis area, and went there, but all the gastroenterologists, either weren't taking patients, or all the ones that were in network or, full and that, because, most of them were hepatitis C. So even the ability to, find a physician was difficult. But like I said, he just said, okay, we'll continue on with what it is because it seems to be working and we'll monitor it. And he, had all the records sent. And so, he was fine. We were, coasting and everything was good until 2016, 2017, when there was, pressure with letters and things to switch over to the generic. But for us, in terms of, Baraclude and with the copay assistance, we were literally $0 out of pocket. So we had no reason to change. And I would guess that the Blue Cross Blue Shield, and they switch, their prescription providers because they don't do their own fulfillment. We went to Express Scripts and other places. Like every year they would change something and went through the whole thing and switch it over, and everything was fine. It started with Ingenio RX in 2019, mid 2019 is when we had Ingenio RX, and like she said, concerning mail order fulfillment versus picking up at the pharmacy and all the trouble, and you can only have 30-day supply and all that, just oh, we're going to make it difficult for you. And it's but they said monetary wise it was manageable. It's a lot of more trouble and time, but at least we got the medication and didn't have to worry about it. So everything was fine in till beginning of 2020. And next slide. So that's when, besides on top of everything else in that terrible year, the Bristol Myers stopped their patient assistance program for the copays. And the normal auto call fulfillment in the beginning of the year every single month, and that, and I don't recall because my wife did it all. It was all the you don't ever talk to a person. You pick it up at the thing. You don't ever talk with anybody, and everything is automated, and they say things over and over. And it mentioned that the patient assistance program went away, but she picked it up at the pharmacy, and then like any other time, and then went on the next month in February. Picked it up at the pharmacy again, after the renewal for the month, the 30-day supply. And a couple days after the second pickup of the prescription in 2020, we receive a bill directly from Ingenio RX. Like I said, for the copay assistance programs or cards and giving them the numbers and stuff like that, versus having it in the system and all that stuff. We'd never received a bill before, and it was a bill for $700. And it's like I looked in our benefits, scheduled benefits for Blue Cross Blue Shield, and they say $200 copay, especially pharmacy. And over the years, I've looked at many times. It's like, what is this? $500 brand name penalty. So that was, like I said, a month after we had already picked up 2 prescriptions. I had multiple phone calls, called Blue Cross about, this is the thing. They say, no, it's the prescription provider. Call Ingenio. They say, no, it's a part of your insurance plan. So go back and forth. And finally, I was able to, talk to somebody. Okay, what do I need to do? It was make sure you have a prescribe as or dispense as prescribed, and then that should take off the brand name penalty. But we had that, dispense as prescribed for the whole time. They wanted it renewed and on the record and all that stuff. And it then picking up in March, I was then, proactive and, and made sure, yes, it was actually a $200 copay. So, so that's fine. It was all that stuff, but then went into, the grievances, our appeal process with Blue Cross Blue Shield. And, it's like this brand name penalty isn't part of our schedule of benefits. And unfortunately, I didn't, I tried to work it out myself through phone calls and stuff like that versus a patient advocate and, somebody that actually knew the system. In Illinois, here, I said in California, learned a lot about the disease. In Illinois, learned a lot about how insurance companies work. And then now as we go here, it's like, okay, now I got to learn how prescription plans work and how they change. And, you have to, because nobody is on your side. Hepatitis B Foundation, when I, finally ended up calling it, I was literally at the end of my eyes, like, I have no idea what to do. I don't know, this is happening. It's, obvious. It's like, what recourse do I have? And they have, a lot of different help, help and things to go to the, different insurance boards and things like that. I was trying to work it directly through the, insurance company, and month to month it was $200 copay, and due to COVID and manning the phones and getting people on phone that weren't working from home, and the doctor that really wasn't familiar with hepatitis, he retired, and then it's like we had to find a new doctor, and it's like, well, the first time we'll be able to see it was after 3 or 4 months. And finally, we see a new doctor in July, and it's like, well, the year's prescription that was done with her old doctors is running out. We need to renew that. It's like we can't even have a doctor because we can't do that over the phone. We have to actually see it in a physical treatment, and they weren't seeing patients, and this that. So it was very difficult, but that wasn't anything due to just the difficulties and health concerns with COVID, but that stacked on top of everything else made it, very difficult. Like I said, this is, 2020, it just made everything worse. And unfortunately, Bristol Myers, discontinued their patient assistance program. But so we finally were able to, get in to see the doctor. And it was like I said, at the end of her year prescription, she had to renew. And just due to, like I said, the way the slow things worked, we had to switch to the generic. The doctor says, like, the only way we're going to be able to, continue on, and, so you don't run out and get this, new doctor and new sending prescription to a new place is to do that. And I was basically, calling up, making sure walk through, even though it was the generic, it was, like I said, it was hours of the phone call, not hours, multiple hours, just to even to get the generic endosevere fulfilled for that first month, because the very first month, or from a crossover for a new prescription or something like that, it's just a lot of work. It doesn't happen automatically. And so that, and finally, so things worked out. And but in the meantime, as I said, it's still the $20. There's no benefit from a brand name to a generic. And there, so we're, $200 a month. Still, it's not as bad as some of the numbers that Michaela presented, which are, oh my gosh, horrible. It's like, I feel, sort of lucky that they weren't as bad as everything else, but it's still, $2,400 a year. It's the decision between, you cut your pills in half or whatever, those things we don't, even consider, because, the importance of the continuing treatment, because, for 11, 29, for 10, 12 years, she's been religious about every day. You can't eat, I don't know, it's 1 or 2 hours beforehand, and you can't eat 1 or 2 hours afterwards. So she has it in the morning, but every day that's religious, that she does that, day in, day out. So we were, looking for ways to do that. And we had seen commercials of GoodRx on, TV, and inquired with the CVS, which is the pharmacy here. They're actually, well, we didn't do this, but hey, let me tell you, CVS is part owner, or Blue Cross Blue Shield, somebody, owns a specialty pharmacy. So that's why they wanted here. But if you, bring the, use GoodRx somewhere else, then you'll most likely save money. So it was like, of course, we inquired at Costco, and then they said, yeah, next thing, make sure you get the prescription transferred over here. And we waited a month, in the meantime, paying all these other bills, and that, since it was under dispute, we didn't pay the penalty. Excuse me. But everything was, billed, and and since July we were paying at the pharmacy whenever we picked it up, $200, and that was just the cost of doing the prescription. Nobody was telling us. We picked it up there, and literally the first month I picked it up at Costco, I thought it was they were kidding, or it was a joke. They said, no, it's less than $20. I said, it's like, really? So anyway, that was great news, and we've been using it ever since there. But the insurance company didn't say anything about that. They had their own interest. Like you said, it was for the money, or they had their own stake in the pharmacy, and they they're not there to, supposedly they say they're there to improve your health, but they're there for their money, not yours. So next slide. So I said it was a whole storm of bad things, and at the end, I look on the bright side, is it actually sort of worked out. But if I would have, like I said, I got the education of the disease, how insurance companies works, and how prescription plans work. And it's like, oh yeah, after 9 or 10 years now, it seems manageable. And I hope that other people as well can take advantage of the lessons I learned. And I'm not advocating a specific thing, but like I said, GoodRx worked for us, and I know there's 3 or 4 other ones that help that. But if you don't know about that, you're stuck. And like I said, the insurance companies take advantage of it, and the amount of time it takes trying to track that down and do that, and the financial strain and all this stuff. And they're like, nope, these are what the rules are. It's like, but and the very sad thing is, like, I don't think our story is unique. And at the end, it was even worse after we figured all this out, and finally things are back to normal now, a bit better with her prescription, and going to pharmacies and stuff like that. At the January of this year, we got a notice from thing after all the appeals were denied. So all the appeals were denied. They said, no, you still owe all this stuff. You're in a real. They turned over the account to the collection agency, and the credit scores, stress, and all the things, like $1,000 this. And then in January we get a notice to say, oh yeah, by the way, last year we overcharged you. Not much consolation after the stress of everything else. But I said, you look through the bright side and everything, and it's just a pain to get there, and it's undue stress. And like I said, they make people jump through hoops. They don't nobody's going to be your advocate except for yourself. But Hepatitis B Foundation has been really, I mean, they're the reason how I was able to find my way through the just the bureaucracy of everything, and they've been a lot of help, and I thank them for that. And I hope you guys, as I said, it's real life. So I thank everybody and this opportunity for the this presentation. Thank you.
Thank you so much, Sandra, for sharing your personal story. And unfortunately, you are right. It's not a unique story that we're seeing here in the United States. Not even just for hepatitis B, many other illnesses as well. So I just wanted to put out our phone number and my personal email address for any questions or things like that. And we'll turn over to Kyle. I believe he's moderating a Q&A. We're happy to answer some questions.
Awesome. Thank you so much for providing all of that information. Andrew, thank you for sharing your story. It's really harrowing, and it's really an inspiration to see how much work you put in, but also frustrating how opaque a lot of these processes can be. So thank you for sharing that, and thank you, Michaela, for giving a great presentation. So to the folks who are watching, please, this is your opportunity to ask any questions. I know there are a number of social workers on here who work in the field of resource linkage, so I know some of y'all have some questions. So while the audience puts on their thinking caps, I actually have a few questions of my own. Could you actually define for me and for the audience what a formulary is?
Oh, well, when you have a specific, disease or condition, they have a list of what they call approved treatments. They have their own doctors on staff, and they go through there. And unfortunately, I think, a lot of their decisions aren't based purely on medical things. They're for cost. Mm-hmm. So it's accepted thing. Like I said, there's no difference between the brand names and generics, but they, I don't know, I think I didn't maybe mention is, later on, after we'd already switched to the generic, they sent a letter, the Blue Cross Blue Shield, saying, we will no longer even accept, any prescriptions for that. If you choose to continue with Baraclude treatment, you have to pay it all yourself. It doesn't even exist anymore in our formulary. So, that like I said, change that in the middle of the year. Like I said, luckily it was, they said, starting September 1st, we will no longer, accept any prescriptions for that. You're on your own, which basically they say, that formulary of the brand name doesn't exist for that. So that answered the question.
Just to be clear, a formulary is just a list of approved treatments.
I believe so. And then, like I said, they have their own doctors on staff and say, oh, well, because there's a thing, I think, they have the experimental versus accepted. And I believe the formulary is just the, accepted ones that this insurance company, accepts as approved treatments.
Yeah, if I might just add, it also determines how much you're going to pay for the treatments. So that's some of the slides showed that, but depending upon a number of different factors that the insurance companies have, and it varies by state, sometimes even county, they will place different treatments for different drugs in different tiers, and that determines how much you will pay per month or per dose of the treatment.
I said, I believe it's general for insurance companies, but like she said, it's also individual for the different plans, because every company has their own agreement with that. And then the insurance company has their own agreement with the prescription fulfillment. So it's, it's like you call a different person a different day, or, next year it changes every year, or like she said, right in the middle of everything, think what's going on. They know you have to switch to this, or so that's,
Thank you for that. And would you say, these kind of insurance documents, formularies, as well as any sort of other informative documents that insurance companies put out, would you say there's a barrier to understanding a number of these things? And if so, what advice would you give to folks who are looking at something like a formulary for the first time and thinking to themselves, what is all of this?
Well, a lot of the stuff they have online, but every single year they send out the book. I have it. It's like, the book of what the plan covers, and everything every year is changed. And then, like I said, in the middle of the year, they can change that, but it's like fine print, and you have to, keep up to date on all that stuff because they have their team of people, doing that stuff. And like I said, it's fine print. It's like, oh yeah, of course we said that. We sent you this letter, or we did that, or we changed it for 2019 effective, April or whatever. So I would believe it'd be a lot more prevalent on the higher tier systems because they're always trying to, like I said, all for cost versus a generic, tier one where they're just issuing, for lack of a better, an aspirin or a painkiller or something, allergy medicine that is still a prescription, but it's millions of doses, and you can buy it through a pharmacy with not much problem at all. The lower tier drugs and stuff like that.
Some other issues that we've also seen regards to documentation is, I would say 100% it's a barrier because it requires a certain amount of health literacy, which I think Andrew spoke very well to about how much time you spent reading things and trying to learn it. Some individuals don't, have that time on their hands if they're working, maybe 2-3 jobs or, other things of that nature. It can be very, very difficult to find the time to do that. But I also wanted to mention that with the hepatitis B community, I mentioned a lot of them are perhaps immigrants or perhaps minorities who English may not be a first language. Of course, they're offered in other languages, but we've heard from people personally that, even bringing this to the attention of insurance companies where they have to go find it and the company has to find an interpreter for them and things of that nature, it's a significant barrier for them to understand what's going on with their own health plan, or even to report it to the state as well.
Yeah, and that's like you said, that's one reason why I was doing it for my wife. English is her second language. English is my primary language, and I still have trouble. It's as bad as the tax code, or worse than a tax code is health insurance and their books and stuff like that. It just it's fine print and books of regulations and their rules and stuff like that. It's that's they're in the business of doing that, and a barrier, yeah, because everybody else isn't a full-time participant in that. They just want to use the plan, and yeah, I mean, hours and hours in direct contact with the company and asking about appeals for their stuff, as well as just reading the book and then reading other stuff online, whether it's through the actual insurance company or other examples. And like I said, I can't say enough about the professional or the resources provided by the Hep B Foundation. That was invaluable for that. And as I mentioned, in California, just due to it's all immigrants are not in California. My wife was like, yeah, that's one reason why we should stay in California, is because everything worked so much better out there. Whereas in Illinois, it's like they put up barriers and just wanted you to basically either go away or to make it difficult. I don't know. I don't think it's malicious. They just it's like a low percentage, so they can do what they get away with or what they want. So.
Yeah, and this is where healthcare advocacy becomes tricky in this
Yes.
country. The need varies state from state. So yeah, I applaud you for brushing up on the various ways legislation or health insurance impacts health outcomes. So yeah, thank you. So it looks like we have 2 questions so far. So does Hepatitis B Foundation offer services to patients to help get them through all of this. Can you provide some examples of what Hepatitis B Foundation offers currently?
Sure. So there's a few things that we offer the AIDS patients. One is that we, as I said, we have a helpline, we have an email, social media, phone. You are available and more than welcome to talk to us at any time, tell us your issues, and we are willing to talk it out with you. Some of them might be more complex than others. So whether it's just helping you find a basic understanding of what's going on, whether it's understanding your plan better, we're available to help you. We also have on our website underneath treatment options, I believe, it will be medication assistance page where we list several resources in the United States where you can access treatment at a cheaper cost. So just comes to mind, RX Outreach is one of them that offers some treatments. Another one might be GoodRx. Yeah, so there's discount pharmacies listed, there's manufacturer assistance listed, there are online pharmacies. So several different resources where you can do that. And then another thing that we've started doing as well, and one thing that we're really bolstering our advocacy around, in addition to education, because as I said, a lot of people just don't even know this is happening. They kind of accept it like, well, this is my plan, I have to pay. If it is in the federal marketplace and it is illegal happenings going on and discriminatory, we can assist you with submitting a claim to your state insurance commissioner as well. That's something that a lot of people might find a little intimidating and something that we're working on. So stay tuned. And late fall this year, we are putting out some resources to help out with that. But there's a number of different ways that we're able to offer assistance. Number one being our website just has a list of our resources that you can easily access yourself.
Wonderful. Thank you so much. And that website again is?
Oh, I can pull it up. Well, it's not on here. www.hepb.org. So just like the last part of my email.
Awesome. And if any audience members needs a link or any sort of connecting to happen, you could reach out. You could reach out to Cheetah at fight.org, and we'll happy to connect you folks to resources. So additionally, the same person says, insurance companies should be held accountable for these somewhat scrupulous tactics. Why aren't they, and what can be done to prevent these tactics?
Yeah, that's a really good question. Something that we wonder all the time. I will say it is a very, very complicated issue. Andrew and I tried our best to simplify it for you, but there are numerous laws that come into play. Number one being not everybody's on the federal marketplace. A lot of these are private companies that do not fall under the same restrictions and guidelines that the ACA has put into place. Different states have different relationships with the ACA. It's another factor. Another one being, and this is something that we have heard directly from insurance departments, state insurance departments, is that not enough people come forward. And that is something that we're really, really working to change, is that they come to us. And even out of the number of people, we have a large number from us, there's an even larger amount of people who are just living with this issue and don't even know what's happening. But when no one's reporting it to the state insurance departments and the state insurance commissioners, they technically have no basis to go off of. They have nothing really documented for them to look into. And so that's something that is really, really important to change. And every single state has an insurance department where you can submit a claim and an official complaint. And once the state receives their official complaint, they can take action. They can do their own research. They can look into it. And once they look into it, if they find out it is indeed discriminatory, they have the ability to enforce those laws. Unfortunately, we don't. We're a nonprofit organization, a community organization. We love to hear from you. We love to know what's going on, but we just don't have that kind of power to hold them accountable on such a large scale for everybody. So I would say that's probably the main thing, is that just not enough people come forward.
Gotcha. Yeah. Wow. Yeah, a lot to chew on. So folks, we have a few more moments left. So please, if anyone has any questions, please, please, please ask away. I have kind of like a soft question. What advice would you give to folks who are interested in healthcare advocacy and patient advocacy?
Andrew, you started it. I can let you kick it off.
Well, I said, unfortunately, I had to do it. I said, it was like literally, and you talk about the emotions and Jason and stuff like that. My wife as well. I mean, just the stress, and she made the statement. It's like I gotta choose between food for my kids and medication costs for herself, and she did have that guilt and stuff like that, and thought is like, well, if I just stop, I know my uncle passed, but he was older and stuff like that. It's like, no, honey, it's like, try to like, do not even consider that. We will find a way to work out. And like I said, unfortunately, some people don't. And this is, just one example of a barriclude, entosevere, and that kind of, timing and bad stuff. But for all the other drugs, I'm sure it's a similar path, because they all had the similar expenses, and some are not brand name. And the, in that sense, there is no help, but it's once you start, you can't stop. It is worse for you. Like I said, my wife would say, well, if I never would have started to begin with, I have to take this for the rest of my life. It's like, yeah, unfortunately, that is it. That's, the nastiness about this, disease. And, like I said, she has siblings that are clear and that, but, and you say in California, I believe it was mandatory at pregnancy to test the mother, just like donating blood and everything, the HIV/AIDS test for that. And maybe that's one way, mandatory testing. They test for all these other, genetic things in there. And I don't believe, that I don't know, quite. I mean, Michaela mentioned that, people aren't even tested and they aren't given the vaccine. Like I said, my kids definitely were, because of, where we were at and the Kaiser Permanente. That was just their policy. So, fortunately, none of them, have it. They were, tested for resistance as well as I was. So there is, prevention, and that's, like everything. The prevention is a lot easier than a disease. And it's the simple, vaccinations around the world or whatever that have this. Unfortunately, you can't go back in time and all that stuff, but there needs to be a plan or I mean, a way to get through this. Otherwise, it is, almost like a death sentence, or condemned to, cirrhosis and liver cancer. It's, the liver is a very important, I said I became an expert. The liver is like, oh my gosh, I don't know even, I stopped drinking. It's like, yeah, I take care of my liver, my wife, all this stuff. It's like, you can't take your health for granted. And, everything, and it's in the back of my wife's mind. And that's, just that is like, I have to be here for my kids, and I can't, do this. I can't do that. I can't, do this. And, it's a very serious disease. And unfortunately, it is life and death. And like you said, the education, if you don't know you have it, you just, by the time the viral loads get so high, it's a sad fact that there's really nothing they can do once the liver is damaged. It's just a, downward spiral for all that stuff. So
prevention. That is a great message. Yeah. And your family's lucky to have you as an advocate.
Yeah. I would just like to, so just to clarify something, like across the United States, all pregnant women are tested for hepatitis B. It's like I'm a part of a panel for a lot of things that pregnant women are tested for. Although universally, all adults are not tested for hepatitis B. So, your hepatitis B status can change at any point in time. So it's really, really important. I think Andrew made really great points. There's different levels of advocacy. One is for that education piece. if you don't know anything about hepatitis B, then it makes it really complicated to advocate down the line. For resources, we need prevention, we need surveillance for hepatitis B, so we can, estimate the true numbers and how it's being transmitted in the United States. We have all of these things, and we have all of these resources that really just need to be put to hepatitis B and utilized for this. But another thing is that your voice matters. You telling your story like Andrew did today, it can be daunting, but it's important to let other people know that, you did this so other people don't have to. It's important when, people are coming to the foundation to know that their story is not, just sitting there with us. It's being utilized to provide evidence that this is happening. We track the fact that discrimination is happening and what states we're hearing it from, how much people they're paying, because all of this matters when it comes time to trying to secure funding for these research efforts, not only for us, but for other groups. And when we're advocating why the CDC is so important, Center for Disease Control and Prevention, and why they need resources to help track hepatitis. So there's a whole number of different factors, but at the end of the day, you telling your story, you sharing your voice with your community, is part of the reason why we have just these storytellers, who tell about how their background with hepatitis B and their relationship with it. It's to let other people know that it's okay. Hepatitis B is similar to HIV, highly stigmatized, especially in minority communities. They don't feel comfortable sharing, which is one of the reasons why transmission is high. No one knows, what to say. No one knows how to interact with it, because no one knows that it's really a big problem, or if it is a problem in the community, they're silent about it. So making people feel comfortable, destigmatizing it is a big part of our advocacy efforts. And we encourage everybody, it's okay. It's a disease like any other thing, and it's okay to live with it. And, you have support, and we're here for it, but just telling your story is powerful enough.
Michaela, thank you for that. And, oftentimes I've heard hepatitis B described as the forgotten topic, unfortunately. So I think the work you all are doing, pushing it to the forefront, is tremendous. So thank you for that. So it looks like we have one more question. Are these practices happening in Medicaid programs as well? In terms of advocacy efforts around this topic, what strategies have been the most successful?
It's a really good question. We have not specifically looked into Medicaid when it regards to this, although I imagine it might get a little bit more complicated because Medicaid follows such strict rules. It's not just, what we're dealing with, anything in the federal marketplace, because that is covered by the government. I'm sorry, what was the second half of the question?
Covered by Medicaid as well. In terms of advocacy efforts around this topic, what strategies have been the most successful?
Yeah, sure. So in terms of advocacy efforts, this is still really new to us. So prior to 2019, it was a lot of 2019, 2020, a large part of it were in the research stages. Getting the word out that this is happening, that's something that we're working for in late fall this year, is just doing consumer advocacy. So that's one, putting that report together was really, really helpful, because the consumer report is not only a resource for consumers to use, for people living with hepatitis B, but it's something that you have, and that not only us, but that the consumers can use to take to the insurance commissioner. They can take it to their state legislators and say, look, this is what's happening in your state. We have a list of, I think, the 14 states we went through, and we pulled out the insurance plans that had examples of discriminatory tiering in them. We've met with Pennsylvania and the insurance commission in Pennsylvania to discuss the issue. And, unfortunately, this is a process for a small team, and it's a state-by-state problem. But I can't say this enough, bringing it to the attention of your insurance commissioner, of the insurance department, is probably the most helpful advocacy that you can have, because it needs to be documented. They need to be aware that this is happening, and they need to be aware that it's an issue. But besides that, just sharing, the fact that this is a problem in the United States, doing presentations like this and raising awareness is key to the advocacy efforts.
Awesome. Thank you so much, Michaela.
Mm-hmm.
So it looks like that's about it for questions. So I just want to ask you both to provide your final thoughts for our audience today, and kind of leave them with some more nuggets before we conclude.
Okay.
Okay, well, so like you say about the forgotten disease, if my wife had been, if I wouldn't have loved her so much, I wouldn't have even known about this. I'd be going on with this. It affects me personally, and I had to do it. It's that, but you're exactly right. I didn't think of 1 second, millisecond of my life even thinking about Hep B, and I like I said, unfortunately, I had to. When I get into it, I have to really do it because it's not that I feel I had to, but it's like I if not me, who else? And it's like it was as important for me. Like I said, the insurance company isn't going to look out for you. They're in their business, and I, was looking out for, my family and trying to maintain the health. And, it's sort of scary that's, and daunting. And like I said, actually, before my first child was born, we actually did go to the funeral of my uncle, or my uncle-in-law. And, he had come to our wedding and all this stuff. And within a year or so, he had passed. And it's a serious thing that happened. And like I said, if you're not informed, or you don't know, or not monitored, it is a silent killer. You just your liver does so much, and feeling of just bad and terrible, and because it just that, like I said, the only reason why I did stuff is because I'm just in this situation. I said I had to. It's luck and not luck. It's just I do think I'm very appreciative of the Hep B Foundation and everything, and the resources, and there's other ones too. And it's like anything else, you look on the web, the doctors is like, oh, you just must have found that on the internet. It's like, well, there's good resources and bad resources, and information, and this treatment and that treatment, and all this stuff, and Asian medicine, and we went through that. And I said, in California, very professional. It's like literally the experts doing all the research, and at the cutting edge, and clinical trials, and all that stuff. But it's it's a pipeline of drugs, and just like HIV/AIDS, viruses are nasty things. And I said it's like chicken pox. It just stays in your liver, and you get shingles, or it just builds up in your blood. And unfortunately, the stress of pregnancy and childbirth, it made it there. I mean, if it wouldn't been for that, I don't know if she would have ever gotten treated either. There's all that stuff of just, you got to look on, the blessings you have. And, it's like the worst thing you want to do is, wake up the next day and, and have the whole world, feeling terrible. Like I said, there's times, a lot of ups and downs, over the past decade. So it's unfortunately, I hope we're through it again, and until the next crisis. But like I said, it's nobody else was out there to do that, and it was a lot of work. But like I said, I can complain about it, but it's something they had to do, and I'm glad it's done and behind you, and you got to learn from it. And like I said, be able to help others, and give others advice too. Like you said, these little bitty things. He's like down for a month or two. It's like, oh my gosh, you got all these bills, and the collection agency is writing letters, and I'm writing appeals, and then the next thing, like I said, the really crazy thing, I touched on it a little bit. It's like, oh yeah, by the way, in 2021, yeah, we made a mistake. It's like, that was it? I just get a check that says, yeah, we're refunding a thing for an overcharge, where I was, for 4 or 5 months, I was filing appeals and saying, the scheduled benefits don't match there. Why are you charging me, another $1,000? So.
Yeah, I would say that I think it's just really important to remember 2 things. One is that you have rights You have rights, and you should be able to utilize them and access them and fight for your rights, because that's one thing that's so key. And one of the things foundation of the United States is built upon, you have these rights and you should be able to exercise them. And the second one is that this is not in a bubble, this is a health equity issue. Not being able to afford your medication, not being able to access it, it is no fault of your own. There's a health equity issue that the United States in its entirety needs to work on for multiple diseases. And you are, you could be a part of the solution. You can help, by sharing a story like Andrew, and we need people like Andrew to really speak up for themselves. It's never easy. It's a long process, but it makes a difference. Even if you don't see it immediately down the line, that's how change is built. Change is a slow process. But we are hopeful that we have a new administration with a spotlight on health equity. We're hopeful that, a lot of states are beginning to realize how important this topic is, and we are more than willing to fight right by your side for this. So we really need to work on this, and it's just so important for people to be able to afford their medications.
Absolutely. Absolutely. Andrew, Michaela, thank you so much for providing your story, providing resources, and this call to action. And let's hope that discriminatory drug tiering in the future will no longer be a barrier to care. So thank you so much for this. And thank you to our audience for sticking with us. Everyone have a wonderful day and take care of yourselves.
Thank you so much.
Take care.